Do you want me to go ahead and share my screen?
Thanks everyone for joining us today. We're just letting everyone in from the waiting room and we're going to get started momentarily. So in the interest of time, I think we should get started. And a few additional folks are likely going to join us from the waiting room. Hello, everyone. My name is Stacy Chazen, and it's my pleasure to welcome you all to the second session of AIDPH's Rural Echo, focused on risk-stratified care for dental teams. Next slide, please. We want to thank our partners for this program, the CareQuest Institute for Oral Health, the University of Nevada at Las Vegas, and the Oral Health Progress and Equity Network. We value your support and contributions. On today's call, we're going to welcome you, which I've done, go over some housekeeping items and provide an overview of the call. We're going to hear a presentation from Caroline McLeod with the CareQuest Institute for Oral Health on risk-stratified care for dental teams. We'll then have some time for a Q&A with all of you. We are then going to hear a case presentation from the Louisiana Oral Health Coalition, have a discussion of that presentation and offer some guidance to the presenters, and then we'll wrap up with some next steps. So going over some brief housekeeping items, today's call is being recorded. We're going to ask everyone to type their email address and organization in the chat for recording purposes so that we have a record of who's here. You don't need to type your name because that's captured when you type automatically. All slides, forms, and other materials from today's call will be available following the call on the AIDPH website. We want to offer a friendly reminder to avoid sharing any protected health information or personally identifiable information during this session. And if you have any questions about using the Zoom platform during the call, please chat Annalise in the chat box. So I think if you're here, you probably are familiar with AIDPH, the American Institute of Dental Public Health, which is a 501c3 nonprofit that is centered on health equity as a cornerstone of oral health education and training. And I encourage you to visit the AIDPH website at aidph.org if you'd like to learn more. Real briefly, AIDPH's vision is for an equity-oriented oral health workforce prepared to lead. The organization's mission is to foster professional excellence and advance innovation in the education and practice of dental public health. So what is an echo? Particularly for those of you who are joining us for the first time, you may have heard the term echo used for health learning models across the country in a variety of different topics and spaces. Essentially, an echo is a knowledge sharing network that's led by a team of experts known as a hub, using a video conference driven practice model like we are here on Zoom today to empower local health professionals. And as the graphic shows, the hub, which is the group of experts at AIDPH and some other subject matter experts with whom we've contracted, make up that hub. And each of you here today is a spoke. The idea, though, is not that we teach you didactically and say, this is what we think you should do or what you can do, go ahead and do it, but that each of the spokes on the call learns from one another. We also learn from you at the hub. And so it's a multi-directional learning model where everyone is expected and hope to be an active participant in the teaching and the learning. So about this Rural Oral Health Echo. The Rural Oral Health Echo follows the CareQuest Institute's 3 domains framework using the lens of rurality and health equity. And that includes teleprevention, minimally invasive care, and integrated and personalized care. And the idea and the hope is that you take knowledge back to your communities from this Echo to implement in your daily work and build the capacity of your local oral health workforce. Here on this slide is an overview of the topics we'll be covering in our monthly calls. You can also find this on the AIDPH website with registration links. And as this list shows, in the month of March, right at the very end, we're covering risk-stratified care. Here's a reminder on this slide. I'm not going to read it to respect patient health information. Our norms for this session and all sessions in the Echo is that each person learns and each person teaches. Everyone uses first names to facilitate equality in the discussion, so we're going to avoid any use of the terms doctor. Always introduce yourself when you're asking a question, include your name, your organization, and your location before speaking. We ask you to keep your video on the whole time, but to keep yourself on mute until you're ready to talk. Try to limit any environmental distractions in your space and to respect one another in the conversation. It's okay to disagree for sure, but we ask that if you do so respectfully. And with that, I'm going to introduce the speaker for the didactic portion of today's call. Caroline McLeod is the Value-Based Solutions Manager for CareQuest Institute for Oral Health. In that role, she supports education, research, and health improvement programs that are centered around oral health and value-based care approaches. Caroline's dental hygiene experience ranges from traditional practice to school-based and mobile programs and clinical teaching. She's a member of the American Dental Hygienists Association and serves as a delegate for her local district of the North Carolina Dental Hygienists Association. She's also an advisory team member for the North Carolina Oral Health Collaborative. Caroline is a graduate of the University of North Carolina at Chapel Hill with a BS in dental hygiene and a Master of Dental Hygiene Education. She worked previously as a teledentistry specialist and educational trainer for Mouthwash. Caroline, thank you for joining us today. I'm going to turn it over to you.
Thank you so much, Stacy. I appreciate the introduction. And I just wanted to say how excited I am to be here today to discuss risk-stratified care with you guys, as I think it's truly a vital part of the 3 domains framework and personalized and equitable care, that goal we're all after. And then the only other thing I wanted to say is I can't see the chat right now since I'm sharing my screen. So if you have any questions while I'm going, feel free to put them in there. I just won't see them until we get to the questions portion. And if there's any pertinent questions, Stacy, feel free to call them out.
Thanks, Caroline. And for that reminder, we're going to ask folks, you can either post a question in the chat, or if you'd like to be called on verbally during the Q&A session, say that as well in the chat, and I will keep an eye on that for you.
Sounds good. Thank you, Stacy. All right, so we're going to get started. We have 3 main objectives for today. The first being to define risk-stratified care. Second, to describe opportunities and challenges for practicing risk-stratified care. And the third is to apply the steps of risk-stratified care to your practice environment. So I want to start by defining the concept of risk-stratified care. So just simply put, risk-stratified care is defined as the process of assigning risk status to a patient, then using this information to direct care and improve overall health outcomes. And since in the definition it says it is a process, that definitely means there is some work involved. But I think there are important reasons why we have to start thinking and practicing this way. In the literature, we really see that risk-stratified care is practiced more in medicine than in dentistry, but we've seen some positive outcomes and can apply those lessons learned in medicine to the way we practice dentistry, with modifications, of course, appropriate for our patients and our oral health services and our expertise. So before we dive into the concept further, and now that we've got a standard definition of risk stratified care, I wanted to ask a quick poll question, and there it is on the screen. I hope everyone can see that. So I'm curious, on a scale of 1 to 5, where 1 is, maybe not as familiar, and then 5 is very familiar. I'd love to understand how familiar you are with risk stratified care. And if it's a new concept for you, that's totally okay. Feel free to be honest. These answers are anonymous. So I'll give you just a few seconds to do that, and then we'll see what the results are. All right. I think that was enough time. Annalise, can we see what the answers are? Or see what the results are, excuse me. All right, so it looks like we've got the highest amount of people maybe not as familiar and maybe a little bit familiar, but we definitely have some people that are, neutral and kind of familiar with the topic. So it's great to see the good mix of people. So, we've got a variety of familiarity in the room, and I'm excited to have discussion with you guys who are familiar and not familiar. So thank you for taking the time to do that. All right, so I wanted to set the stage first and just talk about why risk stratified care is even important. So what really is the value? We've seen that evidence of current health outcomes and costs of healthcare in the United States. It really shows us that one size fits all model, where the same level of care and resources that are offered to every patient is clinically ineffective, and it's really expensive. So to be, on the other hand, more effective with the resources we have as healthcare providers, using risk stratified care enables providers to identify the right level of care and services for distinct groups of patients based on their risk level. And further, doing that and segmenting the population according to healthcare needs allows for personalized care models and efficient targeting of resources at a lower cost, which ultimately produces care that's more equitable, and really that's the ultimate goal and where the main value lies, in my opinion. And this is especially important for rural populations, as they are a group that experiences significant health disparities due to challenges in accessing healthcare and other social influences of health, which I'm sure this audience is very, very familiar with at this point. So I don't have to, harp on that point, but I just wanted to draw out a few examples that I've seen in the literature. First, life expectancy is generally lower in rural than in urban counties. We've seen that rural residents are also more likely to have multiple health conditions compared to people living in other areas. We've seen that rural, non-Hispanic Black adults and Indian or Alaska Native adults are more likely to report having multiple chronic health conditions than non-Hispanic whites, and members of racial or ethnic minority, tribal, or other diverse groups in rural areas are at a higher risk for poor health outcomes. Looking specifically at oral health, many rural communities lack access to oral health providers due to geographic isolation and workforce shortages. And then just the last thing I wanted to mention was that rural counties have a higher percentage of people with partial edentalism, having several teeth pulled when compared to urban counties. So our existing care model of giving everyone the same care, regardless of their health and social risks, is not working, as we can see in these outcomes. It's very stark. So, what can we do differently to start making a difference in these health outcome disparities? Well, that's where risk stratified care comes in. So posing a bit of a solution here to the vast problem that we see. And it's not the end all be all, but I'm excited to walk through it with you guys. And as we go through the steps of risk stratified care, I encourage you all to follow along in the risk stratified care guide that was made by the National Association of Community Health Centers in 2019, which you can actually access through the QR code on the screen. You can just scan it with your phone. And I think the link will also be put in the chat, so you could just click that link and it'll take you to the guide as well. So I'll give you guys a second to do that. And before I get off the screen, I just wanted to say, I did adapt some of the charts that are actually in the guide to include oral health, as the original guide was really made mainly for medical providers, but wanted to adapt it a bit to oral health to be inclusive of oral health. But the steps, really, the basic steps are the same. And you'll get a copy of the slides, my slides, after the presentation. So you'll have that oral health specific info. All right, hopefully everyone had time to open it. So we will start going through the steps. Now that we've talked about the why behind risk stratified care, I want to get practical. So we're starting with step 1, and there's 4 basic steps. And those are the ones I'm going to walk through with you guys, and then you can also see them in the guide. So first, you have to start by understanding who your focused patients are. It would likely be very overwhelming to start with a list of all your patients from your practice, and I've seen demonstrated success with picking a specific population of practice patients and starting with that and making a list. So it could be a certain age group, like adults age 65 plus, or pediatric patients. You could list patients of a certain sex or gender, or you could do all patients with a particular diagnosis, like diabetes, for example. So this way you work with a small number of patients in your list while you get comfortable with the steps. And then from there you can grow. So you'll want to designate someone from your care team essentially to generate a list of patients, and your health or dental record should be able to help you with this to generate the list. And it could look something like this. So I just put a sample list on the screen, something like current calendar year, so you know when it was made, a list of patient ID numbers, and then I've particularly listed age as the characteristic that I'm interested in, or you could list other characteristics that I just mentioned, depending on what you want your target or your starting population to be. So the basis of risk stratified care is this list. So we'll build from this list. So just keep it in mind. So step 2 is to take your list and sort patients by the number of chronic conditions and social risk factors that they have. So before we go ahead and sort, I want to show you, this is a chart of some of the most common chronic conditions, systemic and oral health related, and their associated CDT and or ICD-10 codes. So the list provided on this slide is a little bit different than the one in the Health Center guide because it includes oral health conditions and also CDT codes. But like I said, you'll get a copy of this chart, so no sweat. You'll just notice that they're a bit different. So your health or dental record should be able to help you identify patients with these different conditions. And I'll say too, if you don't use ICD-10 codes, it's completely okay. And it may be easiest to start with diseases you're most comfortable in measuring, such as caries or periodontal disease or diabetes, just as a couple examples that might be on the easier side for you to go ahead and start measuring. But starting small is definitely applicable here as well. You can work your way up to including these other chronic conditions and social risk factors. And again, here's just a recommendation on, who can, in your health center, you could potentially, or your practice, so you could potentially designate too. And I really would recommend having someone who's familiar with patient charting or health record data to help you curate the list with these different codes. So still in step number 2, once you have each patient associated with their number of comorbidities, you can, your list can look something like this. So this is the same information as that first list that I showed you. We just added a column of comorbidities. So starting with that first patient, you can go through the chart of conditions and risk factors from the last slide and count how many this particular patient has. So let's just say we look at their current health record and count that they have 2 conditions. And then you want to do the same for the rest of your patients. So that's just the rest of the list and their associated, these patients' associated number of comorbidities or risk factors. All right, so now we're in step 3 out of 4. So once you have each patient associated with their number of comorbid conditions, your list can look, sorry, am I on the wrong slide? Okay, no, I was on the right one. Sorry for the mix up. So once you have your list, you're going to take the patients and basically stratify them into low, medium, high, or highly complex risk. And low being patients with none or one chronic condition, medium with 2 or 3 chronic conditions, high risk being 4 or 5, and highly complex being 6 or 7 plus chronic conditions. So we'll go back and forth between the two slides. But if you're in low, we'll start with low risk, excuse me. So 0 or 1 conditions, you'll see on our last slide here, we have one patient with 0 comorbidities. So we'll go here in low risk, you'll see the total column in the green row of low risk as 1 patient. So then in the medium or rising risk, 2 or 3 comorbid conditions. If we go back to our list of patients, you'll see we have, I believe, 2 patients with 2 comorbidities and 2 patients with 3 comorbidities. So if you see in that yellow row, we have 3 and 2 listed there, 2 and 2 listed there for a total of 4 medium risk patients. And then for the high risk, you'll see that's 4 or 5 chronic conditions. If we go back here, you'll see we have 1 patient with 4 chronic conditions and 1 patient with 5 chronic conditions. So when we go back here to that high risk column, or row, you'll see we have 1 and 1, so 2 high risk patients. And then for the highly complex group here, 6 or 7 plus chronic conditions. If we go back to our list here, we have 1 patient down there at the bottom with 6 chronic conditions. So you'll see for the total column, we have 1 patient listed as the highly complex in that category. And I want to mention too that this, once you take your list and you make the stratification chart, this isn't just like a static thing that never changes. So you'll want to make sure that over time, maybe twice a year or once a year, for example, you take that group of patients and relook at their risk. For example, patients' risk can change. Just as an example, maybe you have a patient who's medium risk. They have, let's say, periodontal disease and maybe a risk for some food insecurity, but maybe your practice is actually able to work with them and connect them to community resources to lower that risk for food insecurity. So, maybe next time they see you in a year, they don't have that food insecurity anymore. And, you're still working on the periodontal disease maybe, but now they're in the low risk category. And it could also go the other way. Risk can rise for patients, but really the goal is to lower patients' risk. So just want to say it's not static. And I would definitely encourage you to reevaluate risk as time goes on for your patients. So once you have your risk group set, then you're ready to design care models and target interventions for each risk group, low to high. So thinking back to our stratification chart, individuals in the lower risk category likely won't need as many healthcare or social resources as individuals in that high risk or highly complex category. And you should identify not only internal capabilities within your practice, but also external resources to meet the unique needs of patients. And I would very highly encourage you all to engage members of your care team within your practice and community organizations outside your practice, since we know that clinical care is only a small chunk of influences on a person's health. Those engagements outside the clinic are going to be really important to lowering risks of patients. So to demonstrate the effect of risk-stratified care, I wanted to actually share a quick case study from a health center and a learning community that the CareQuest Institute facilitated in 2020. And I'm hoping this case study will just show you, how this concept can be put into practice. So this health center, their target population was diabetic patients with an A1C greater than 9. So they used the system of risk stratification to stratify their patients with an A1C greater than 9 into their own specific target group or population. Providers involved in the risk stratified care process for their particular case was a primary care provider, a dental provider, a pharmacist, and a behavioral health provider. And their care goal specific to dentistry was that by June 1st of that particular year, at least 15 diabetic patients with an A1C greater than 9 would receive a dental visit that includes diabetes education alongside visits with other types of healthcare providers involved in the project. So their care actions, which were based on risk, were in-person dental visits with preventive services and diabetes education, and a teledentistry visit to provide ongoing diabetes education. And actually for their target population of patients who were not only had an A1C greater than 9, but had a risk of food insecurity, the health center actually connected those patients with community resources to address those needs. So patients were referred to a diabetes self-management course, and the health center care coordinator helped the patients to access that course as well. So you can see how they not only gave care inside their clinic, but they coordinated care in the community as well to attempt to decrease risk of these patients. And then their outcomes were fantastic. They saw improved patient experience and health literacy. They saw decrease in A1Cs and health issues related to diabetes, as well as improved health outcomes through the use of telehealth. And then not only did they see those improved relationships with patients, they also saw improved interdepartmental provider relationships within their health center in particular. So there was improved relationships within the health center and with the patients, which was really incredible. So hopefully this example helps you to see how the ideas and the steps can all be pulled together. And just quickly, as my last slide, I wanted to mention that it's not all rainbows and sunshine. It doesn't all come together nicely every time you try, and that there are a lot of dependencies and challenges outside of the more clinically focused steps that we've discussed. But to me, there's more opportunities and rewards, especially in the long term, for practicing this model. So I'll look for just a few common challenges that I've seen and I've found in risk stratification. And I'll say, as I run through these couple of challenges, if there's other challenges that you're thinking of that may be unique to your environment, let's talk about them. I want this to be a discussion for sure. But the first one that I wanted to mention was technology. So many practices, dental practices, may not have the health information technology capabilities to track ICD-10 codes, to automate the risk stratification process, and then to share the risk data between providers or other healthcare facilities. But I would encourage you, again, here to start small. Maybe talk to your team about the technology capabilities you do have and the skills you do have to practice risk stratified care. Pick a provider or two who are interested in trying this. And then maybe, pick a patient population, like we've had some examples shown here today, and go through those risk stratified care steps, see how it goes, and just continue to grow from there. And then the second one that I wanted to mention is reimbursement. It's always a sticky point, especially in a fee-for-service system. It doesn't always align with the efforts it takes to risk stratify. Like I said, it's a process, and reimbursement doesn't always align with that process. And it doesn't always align with the personalized care portion of the risk stratification steps too, especially when it comes to being reimbursed for a swath of preventive care, especially for adults. Also care between medical and dental providers, social support professionals and their resources. Reimbursement just doesn't always align with those things, but I would highly encourage you to just work within the reimbursement allowances that you have and advocate for the reimbursement that you need for your patients.
Caroline, I'm sorry to interrupt you. I'm going to give you a 1-minute warning.
Yeah, absolutely. And then really just the opportunities, really organizing care around high-risk groups just helps you effectively manage your time and will ultimately produce equitable care because of focusing on disease prevention and management and ultimately lower the cost of care. So since we have like 30 seconds left, I wanted to do just quickly, and thank you, Stacy, the last poll. I'm just curious on a scale of 1 to 5, where 0 is not confident and 5 is super confident, how confident you are in making changes to practice risk stratified care after our conversation here today. It could be a small change. It definitely doesn't have to be a huge change. So we'll give everybody just 10 seconds maybe to answer, and we'll see what the results are.
I am going to signal that I think I copied in the wrong question on this poll. So everybody that is responding, I copied in the familiarity question, but let's use Caroline's question that is projected right now to respond. It's the same scale.
Sorry, Annalise, I don't know that.
No, it was my fault. I messed it up. I'm acknowledging I messed it up, and to please use what you see on the screen and how you answer in the poll.
Sounds good.
So as people are finishing that, I want to flag, we have some questions in the chat, but we're
Awesome.
a little behind schedule. So what I'm going to ask Caroline is that as we move into the case presentation, perhaps you could respond in the chat to the
Sure.
question. And then if
Absolutely.
we have time at the end, we'll come back to that.
Sounds good. And just see the poll results. Absolutely excited to see that you guys are confident about making some changes in risk stratified care. So all sounds good. And we will keep going.
Okay. Thank you. So I think we're gonna move now into the case presentation. And as those slides are being called up, I'm going to introduce our case presenters. Celeste Terry is a member of the Louisiana Oral Health Coalition and co-chair of the coalition's policy work group. She's also a dental hygienist, with XHealth Inc., a federally qualified health center in Louisiana. And we are also joined by Dr. Cross, who is chair of the Workforce and Policy Committee of the Louisiana Oral Health Coalition and the dental director for XHealth. Celeste and Douglas, I'm going to ask you to take it away.
Good morning, and thank you both for the previous presentation and the invitation to join you guys today. So Dr. Cross and I are going to be presenting together. I'm going to start off and then he's going to take it away. So the key challenge in Louisiana, as a member of the Louisiana Oral Health Coalition, we were able to develop our report card for the first time last year. And needless to say, we're not proud to have a grade of D, but using the national statistics of looking at 12 areas, we chose to report out on, we came up with a grade of D. So what we would like to do is to move, of course, improve oral health in our state by increasing that to a grade of C. And currently we're focusing on prevention using dental sealants, fluoride varnish, and community water fluoridation. And all three of these areas, we feel like if we address those, we would significantly start to improve our overall state grade. And on the report card, we failed with only 11% of our Medicaid eligible population receiving dental sealants in the age group of 6 to 14. And 50% have had dental caries experience. Again, that number was, that grade in that category was a C. However, you know, over 50% of children having cavities and eventually tooth pain that would lead to lost time in school is not acceptable. So while I have it on the slide, it's just to preference that we do want to improve that from a C to a better, which would affect our overall grade, moving it from a D to a higher grade, hopefully. And then the other thing to take note of is in our state, only 39% of our communities have fluoridated water. And we know that community water fluoridation is effective in preventing, and it is also a cost savings in the long run, and it's relatively affordable in terms of being able to implement that preventive strategy. But only 39% of our state has community water fluoridation, and that brought us to a grade of F. So while we're looking at these things, and we do have school sealant programs across the state, and the health department had been doing the school sealant program where they contracted with a dentist to go out and do the exams, and then had contracted hygienists to go out and actually do the sealants. They changed from that model to being one that would allow FQHCs to go out and provide school sealants. So we've been a part of the school sealant partner program since 2018. And And in that effort, we're wanting to expand because over 91% of our population lives in a dental shortage area, with a large portion of the state being rural as opposed to urban. So when looking at how we could increase access, given the fact that some of our dental hip set areas are geographic, meaning that there are few dentists to serve in that area, or the population was low income, we know that we have workforce issues across the state. So with that being said, the policy work group of the Louisiana Oral Health Coalition has met with several partners, and we were able to come up with a strategy to provide dental sealants using a dental hygienist in with teledentistry, and Dr. Cross was key in effecting that rule change. So I'm going to kick it to him now, since he took the lead on this and has successfully brought us to this point.
Thank you, Celeste. Louisiana is a very conservative state. Southern states in general tend to be very conservative in what they allow dental hygienists to do. So I knew this was going to be an uphill battle, and that we had to find a way, and a way that would not involve a long period of time in order to implement. So we came up with a teledentistry strategy, and this seemed to work very well. Also, some of you probably may remember that a few years back, Louisiana had a big battle with mobile dental programs. And a lot of people still remember this. And a lot of people were, there was a lot of opposition to mobile programs or school-based programs because of this. So we had to overcome that battle as well. Well, one of the things that I came up with was using HPSA scores. By using HPSA scores, we could effectively exclude all urban areas. And urban areas, really, we don't really need the same service in urban areas. So it really wasn't a problem for us to exclude urban areas. And it was a lot of dentists were really happy about this. The one problem though, and was to get dentists to accept HPSA scores, because they seem to be kind of nebulous, even to somebody like me who hears, HPSA every other day, So, but I was able to convince the state board that it was a good way of excluding populations, and there was a buy-in, and the only out of 12 members that voted, there was only 2 dissenting votes, and one of them was somebody who probably just didn't understand HPSA. So it is a strategy that probably could be used in other states. Many people commented they liked the laser focus. The other thing that I did was to only allow nonprofits, and that included FQHCs and governmental agencies, or by doing that, it made it a lot more acceptable to dentists, because we did have problems with the mobile units, and some of them probably were designated nonprofits, but probably weren't really true nonprofits. So it was easy to convince that the state board that FQHCs were true nonprofits, and it would be hard for somebody to start up a program, and get an FQHC designation. So anyways, teledentistry became a very good way of promoting these programs, of having a hygienist work without direct supervision from a dentist. So we were able to get hygienists to be able to work in rural areas, parishes that have HPSA scores, geographic HPSA scores above 15, and to work in schools that have 50% or more of the students that are below the poverty level. And that includes pretty much all of North Louisiana, the worst areas, the top of the boot, as we like to say. So we're targeting the children that need our services the most. So
I'm gonna jump in right here. Apologies for interrupting. I'm gonna give a 1-minute warning for the presentation so we can shift into the
Sure.
question to the group. Thank you.
Sure. So I think that's pretty much all I have to say. One of the other things that we have problems in this with the state was the Medicaid fees are significantly higher for the exam portion of the and so by doing what we hope to do is to get reimbursement for a screening exam. That way, when the patient is referred, the dentist can collect essentially the full fees for that patient, because the referral would be a lot harder if we don't. And we seem to have buy-in for that. We're getting close to getting reimbursement for FQHCs for teledentistry procedures. So I guess I think we could get into the question section.
Great. So I'm happy to read those. So the asks of the group, they're looking for, what are some suggestions for implementing a school sealant program in rural communities using teledentistry? What are some of the lessons learned from similar programs where care is allowed by dental hygienists or dental therapists? What equipment or software is needed for teledentistry? What equipment or software have you used for teledentistry? And is there a tracking mechanism for follow-up of referrals that has been helpful? And before we consider these, we're going to open it up to the group to see, are there any clarifying questions? And then we'll go back to the questions from our presenters. Any clarifying questions about what they're seeking to do or what they're seeking from you? And feel free, we're not a very large group, so feel free to take yourself off mute.
If it's okay with you, can I stop sharing and then I will post these into the chat so that everybody can kind of feel free to discuss a little more informally and in a cozy way.
Great idea. Thanks, Annalise. Okay, and now that we're all on one screen, you can actually use the hand raising function at the bottom, which is if you hover over and click on reactions at the bottom of your screen, then you can put up your hand. Or if you're not seeing that, just feel free to speak up. So highlighting the first question, what are some suggestions for implementing a school sealant program in rural communities using teledentistry? And maybe I'll start off calling upon members of our hub faculty to see if there are any suggestions.
I can start. One of the biggest things that I've seen with implementing teledentistry in particular in the school system is getting buy-in from different people within the school system. So for example, like the school administration in the county is really important. And then when you start working with, patients and their parents, getting their buy-in, and of course, informed consent. That's probably a non-spoken thing. We all know that. But yes, it's important considerations to get that buy-in before you start, because if you don't have it when you start, the process will be a lot less smooth and you'll have less participation from my experience.
One of the things when I did the rule change, I did require education. So, the FQHCs will be required to educate, parents about the benefits of sealants and fluoride varnish. So I was hoping to, help get more support like that. Also, it specifically asked them to inform parents about the benefits of fluoridated water. So I'm hoping to get more constituents, excited about having fluoridated water. I don't know how well it's going to work. We do have a lot of people that come around with their junk signs when you try to get fluoridated water. So
Other recommendations for the Louisiana folks?
Stacy, this is
having-
Jenny. Oops.
Go ahead.
Sorry, David. Go ahead.
No. I'll defer to you, please, and then I'll
Go ahead,
jump in.
Joni.
It's okay.
Thank you,
I
David.
was just going to share. I am not sure of all of the efforts that are going on in Louisiana around telehealth, but I know in South Carolina we actually have elementary schools and some of our middle schools are already receiving medical telehealth services. So one of the things that's just worked really well for South Carolina is to integrate oral health into the services that the students have already been receiving. They already have consent forms signed by the parents and guardians. And so every year there's just an additional question for the parents to say, hey, would you like for your student to also receive an oral health screening as a part of the medical services that they already receive at school? So partnering with an established program that's already kind of running and they've already figured out all the quality improvement parts that they need to change, I think has really worked well for us as it relates to integrating oral health, but also identifying opportunities for telemedicine to have some teeth, no pun intended. That just kind of came out like that, but you know what I mean, as it relates to making sure that it's an opportunity for a kid to actually receive either a referral to the next dental clinic, or if indeed it is a sealant program. So that has worked well.
Thank you, Joni. David?
One of the things I found in our sealant program that we had was the importance of finding someone who would be a champion. When we would come into the community, we would. My experience is in dental schools, and so coming into the community, there was always some skepticism because we weren't a part of that community. And so having a champion, having that champion, and in our case, it was the school district head nurse who really supported us going in, and having her in that position really expanded the buy-in that we got from the rest of the community. So that was a very important feature for us.
that's a great idea. Yeah.
Thank you. Others on the call?
I'll have to add that we're also working on legislation to require an exam before children start schools. And we know that'll give it obviously an additional push. We have to make sure that there's ways for kids to opt out, because some parishes, some of our rural parishes don't have a single dentist, and some just have a couple. And some of the ratios, like Medicaid patients to dentists, it can be 20,000 to 1. So, but if there is a sealant program available, then they're not going to be able to opt out. So
have you been able to form partnerships with, I know LSU has a dental school there, and also the state oral health program in Louisiana?
We're very active in the Louisiana Oral Health Coalition, and I'm also actually very active in the LDA. And AxHealth is actually, we're starting a residency program with NYU. So we'll be able to, and we're selecting the residents that we host based on their chances are that they will do community service. So we're trying to get more dentists, in North Louisiana, if not permanently, at least for a few years till they pay off their loan. So, but there's some FQHCs that haven't been able to fill positions in over a year, and there's a huge vacancy rate. So, that's another reason for the teledentistry program, because we just, haven't been very successful in getting dentists in North Louisiana.
I have a question suggestion on the tracking mechanism for follow-up of referrals. And I'm going to piggyback off of David's reference to a school-based sealant program that he led for a very long time. And I was a part of that leadership team too on the Texas-Mexico border. And what we found is we tracked outcomes of that program using the BSS to collect data and evaluate the program. But on top of that, we also had very specific sort of quality programmatic outlooks that we looked at each year longitudinally. And then for case referrals, we almost use a risk stratified care approach, kind of piggybacking off of what Caroline mentioned, and that the kids who were marked as urgent, needing a dental visit urgently, we had staff within our program who would just call those children and families and try to understand what the urgent need was. And we partnered with community health centers to say, okay, if you have Medicaid, like here are options for you. At one time we had thought about partnering with private practice dentists, although that didn't pan out for a few different reasons. But that was how we both tracked and then brought in risk stratification based on the capacity and needs of our program. So I just wanted to offer that suggestion and also ask what tracking mechanisms you currently have in place.
So I can pretty much speak to that. With the school sealant program, we do have to provide not just sealants and fluoride varnish, but we have to do the complete Medicaid package, which includes exam, x-rays, fluoride varnish, cleaning, and sealants. So when we have those children who are in need of additional services, we can refer them to a provider, and the parents have full choice as to where they want to go. However, we are available to provide care to them, being that some of the patients we see or children we see don't have insurance. We're able to provide care using a sliding scale, which makes it more affordable, which is another reason why FQHC model somewhat works in this program. And from the list of everything is done manually presently. So from the list of individuals that needed a referral, we would have to follow up with the school nurse. Pretty much that's how most of the tracking has been done via the school nurse. So I'm not exactly sure if that answers the question, but I know going forward, we would need to have something in place to make sure that we're just not out there doing services and that kids are actually getting into dental homes. So that was one of the reasons why I wanted to ask that question to this group, because some of you guys probably have been doing this a lot longer than us. And, rather than us learning the hard way, we can learn from others' experiences. So I appreciate the opportunity to ask the question, and welcome any other suggestions or comments, because we're here to learn. The northern part of the state is like a 5 or 6 hour drive for me. So I'm not trying to waste time, want to get in there and do it right. We don't want to waste 3 years to find out, should have done it this way, so.
It's a different world. It's a state with 2 distinct areas. Most all dentists are in southeast Louisiana, in New Orleans or Baton Rouge, and there's very few dentists in rural areas. And actually, it's getting worse. The population of dentists in rural areas are aging, and our former dean of the dental school, Dr. Dean Gramion, was very pro rural area. He practiced there, and he was trying everything he could do within his budget. However, when practices came up for sale, sometimes even in areas that you wouldn't think it wouldn't be that hard to find a dentist, nobody even looked at them. So we have a tough road ahead of us. We know, it's going to get only worse. Fluoridation is actually, there's less parishes fluoridated than when I started practice. You know, it's ridiculous, but you know, we have a real uphill battle, and I think we made a lot of progress in the past few years. Oh, by the way, whoever asked the question with the residency program, it's an AEGD residency program. And we are working, now we'll be trying to get the state board to allow graduates of the program to get a license in the state, you know, on successful completion of the program, the residency program. So that should help also get more dentists in the state, so.
Well, I thank folks on the call for their suggestions. I'm going to go over some next steps now, one of which is that we'll be providing a summary of the recommendations and any other resources that we can identify for you that could be helpful. So our next steps, CEUs are available for today's session. We'll send all of you an evaluation and request form following today's call. We'll also make recordings and resources available on the AIDPH website. As I mentioned, we'll be sharing a summary of the recommendations from today's session, along with some other resources that we'll add in the coming weeks. The next monthly Rural Oral Health Echo session is going to take place on April 26th from 1 o'clock to 2 o'clock p.m. Eastern Daylight Time. And we're going to be diving into teleprevention and teledentistry. So I expect some of the questions that were raised today will come up there as well. And we'll have another set of presenters for you. I want to thank, and also we ask if you would like to present a case on a future Echo call, please submit a case form through the AIDPH website. I would like to thank all of today's presenters and participants. It was wonderful to have you all here with us, and we appreciate your time. Please feel free to reach out with any questions or suggestions about how we move forward, and please do complete the evaluation and CEU request form. We want to hear from you how we did today so that we can continue to make improvements and make sure this program is best meeting your needs. Thank you, everyone, and have a great Thursday.
Thank you.
And Celeste, I
Thank
just
you.
put something in the chat for you, just an answer to your last question there. If you want to take a look.
Oh, yeah. Thank you, Caroline. Thank you. Thank you, everyone.
Mhm.
Thank you. Awesome.